Hi, I'm Dr. Allison Cole, sleep medicine specialist and bona fide chronic insomniac. Welcome to the Sleep is My Waking Passion podcast. Remember, knowledge is empowerment, and if applied correctly, it can help you biohack your way to a better night of sleep, just like I did.
Hello, everyone, and welcome to the Sleep is My Waking Passion podcast. I am your host, Allison Cole, and today I am joined by Dr. Mary Burns. This is going to be a really cool discussion because Mary and I actually connected completely by chance because I have a relative in my family who sees her. And we were talking about sleep and talking about some of the intricacies of treating women and how their sleep changes as they get older, and also some of their requirements in terms of being able to manage their dental issues may change, as a result of those hormonal changes as well. So Mary's very knowledgeable in this area, and that's kind of what we're going to talk about today. So Mary, you are an expert in orthodontics, dentofacial, orthopedics, and you are based in New Hope, Pennsylvania. You've been there for a number of years. You are also a member of the American Association of Orthodontics, a member of the Roth Williams International Society of Orthodontists. You've lectured internationally. I mean, your accolades are huge, and I know that you really are very good at dealing with TMJ issues and dealing with sleep issues. So anything else you'd like to share with the listeners before we get started talking about this topic?
No, I've tried to mix a combination of teaching and practice so that I could educate not only my patients but my colleagues. And so it's my passion too. Just like you have sleep is your waking passion, my passion is to educate my colleagues so that we can have more people that can provide this type of care.
Oh, I love it. I love it. And anybody who's listening is going to be smarter as a result of hearing what you have to say. So what I was going to do before we kind of focus on more of the perimenopausal or postmenopausal woman is just to refresh everyone's brain about what happens during sleep. And this is a very brief kind of picture of what goes on over your lifespan. So when you're a baby, basically, you're sleeping most of the day. You have some active sleep that eventually becomes rapid eye movement sleep. You have some passive sleep. Eventually, that becomes your stages of non-rapid eye movement sleep. So our sleep, and then as we get older and as we grow and we become kids, we start to sleep a little bit less. And women, some big changes. There's really not a whole lot of sex differences when we're kids, but basically it's really about puberty and menarche, or getting our first period. And that's when we start to see that our ovaries kick in, and now we're having cyclical fluctuations in our progesterone and estradiol levels. But that kind of allows us to have kids, right? That's the childbearing age. And there's some really neat things that happen with that, in that they do notice changes just depending on where you are in your cycle with the quality of your sleep. And then also the fact that they've been able to demonstrate that especially things like progesterone and to some degree estradiol, those are likely to be protective of our upper airway. So it actually stimulates the genioglossus, or the tongue muscle, and that helps to keep our airway more patent. So we tend to see lower risk of sleep apnea in women, premenopausally. But then that picture changes as our hormones start to fluctuate. So in perimenopause, we start having what we call vasomotor symptoms, aka the hot flashes. This is when women really start to complain about insomnia, difficulty sleeping, having a lot of wake times during the evening. They tend to maybe have some more restless legs type of symptoms they may not have had before, some periodic limb movements we see. And then we see a whole lot of mood disorders that are likely going to be related to the fact that your sleep quality is always going down. It's hard to say chicken or egg, in my opinion. I think that you can have more than one thing obviously overlapping, but clearly it is a huge problem. I mean, we're talking, once you get to your postmenopause age, it's like over 50% of women are likely to have some symptoms of sleep disruption. So, one of the things that I wanted to get into with you is the sleep apnea piece, because yes, while your risk is lower, it's not zero. It's about 9-ish% roughly with women. It definitely goes up considerably with perimenopause and menopause. So can you talk, Mary, to everyone about some of the nuances of OSA or sleep apnea in women as we get older versus men and their clinical presentation? Because I find this fascinating. This is something that we were chatting about on our conversation.
Well, first of all, I want to start further back because, as you said, yes, women tend to present more with OSA or sleep apnea as once we get to perimenopause or menopausal because of the hormonal changes. Because as you brought up, these hormones do tend to, and is supported by the research, these hormones that women have tend to protect the airway. And I'm sure that's biologic because, these are our childbearing years and there's a purpose for that. However, I want to back up to even before because, there's a spectrum of sleep disorder breathing and OSA is just one of them. And unfortunately, what we're seeing and I see in my clinic is we have young women, and it can start as early as in when they're first starting to get hormones, but typically it's 20 to 40s, and they have a situation that's more like what's called upper airway resistance syndrome, or someone that has a high respiratory disturbance index, but not necessarily many apneas. So they might not show up positive as a sleep apnea patient, but in fact, they're having very, very poor sleep quality. So for example, I just had a patient who's 17 and the mom definitely reported that she felt she's never slept well in her life. We sent her for a sleep study. Of course, it came back and it said that it was normal. However, she had a 75% sleep efficiency and she had 10 arousals an hour. Now, no one has any good sleep quality when you have 10 arousals an hour, but arousals don't equal an obstructive event. So then she shows up as negative for OSA. So what's important for me and for you, Allison, when we're talking about women is, just as this new research came out that most of the research in medicine looks at men's disorders, it's the same in sleep. And women have sleep problems, but they present in a different way. So we have to become very sensitive on how to detect this. So I try to work with sleep doctors so that we can look more at the respiratory disturbance index, which is a reflection of sleep quality, so that we can get our patients treated. I had a conversation with the sleep doctor about this, and if someone is sophisticated enough in the way they were trained in sleep, we can have that respiratory disturbance index interpreted as sleep interruption and get a sleep diagnosis for them, and then they can get treated. The most interesting thing is that the treatment from your aspect, Allison, is still supporting sleep, supporting the airway, and oftentimes is a CPAP. But also from our end, it could be some type of way of creating an architecture around the airway that makes the airway either larger or supported more or both. So that's really the aspect that I come from.
So Mary is bringing up some really good points. So we're going to take a little bit of a step back and we're going to really talk about this respiratory disturbance index. So there's several parameters that we look at. The classic definition of sleep apnea is that you're going to have one of two things happen. Either your airway, your upper airway is going to relax to the point where you're still making an effort, your chest is moving, but there's no flow. So what we see is like a pause in flow for about 10 seconds. And we say that's an apnea. And we often see a drop in oxygen levels associated with the fact that you've basically stopped breathing for 10 seconds. And depending on what age you are, and if you want to go Medicare versus non-Medicare, that's debatable, but in general, a minimum of 3% desaturation. The other thing that we look for are times when the flow is very diminished. So we're seeing some flow, we're seeing a drop of at least 3% in your oxygen levels, and we're seeing that you are attempting to breathe, and we call those hypopneas. So classically, we would calculate something called an apnea-hypopnea index. What we know about women is that their airway may actually, the flow may be diminished, we may not see that 3% drop, but we're seeing these arousals from sleep, or these what we call respiratory effort related arousals, so more mild criteria. So they may have more of this, so we see an elevated index. If we calculate just apnea hypopnea index, we're only looking at 2 parameters. When we include these respiratory effort related arousals, we're now looking at 3 parameters. And essentially we get this respiratory disturbance index as a result of that. And primarily it may be more of the RERAs, or these respiratory effort related arousals, the more mild criteria. The importance of this is how we test people too, right? So a lot of the times what we do is we're doing home sleep apnea testing. And there are some limitations. And there's also some more recent pushback by insurance plans who are like, okay, listen, sleep doctors, we don't really care that you think you know what you're doing. We make rules, and we have people that make those rules too. And we're not really sure that we buy into the respiratory effort related arousals. And I have met other sleep doctors that are sort of like, they think it's exaggerated, or the home test may not be accurate for respiratory effort related arousals, or for relatively mild sleep apnea, which is another issue with women. They tend to present with less severe sleep apnea than men, with more of this upper airway resistance. And so it becomes a little tricky sometimes for us as sleep doctors, because we have to take into account what's going on with the patient, what's the clinical presentation, right? First of all, how does the patient feel? How is their quality of sleep, which is so key. And then we can look at these other parameters, which may or may not be supported by insurance plans wanting to pay for treatment of this, even though it's probably going to benefit the patient. And the other thing too is, if we miss it, some people will be like, okay, well, I'm going to call it a day. And the reality is that when you have more mild sleep apnea, it tends to be missed on these home tests. So pushing for that next step, going the step further, or if your doctor suggests it, thinking about, hey, maybe I need to actually sleep in the sleep lab to get some of that data. It's okay to think about that, because that may be what we need to do ultimately to really cinch that diagnosis for you. And then someone like Dr. Burns may want to talk to you about what's going on with your airway. So, we've talked about CPAP on the show before, using a machine to stent open the airway. Mary, why don't you talk to everyone a little bit about, the types of things that you do to help expand the airway? What's in your armamentarium, if you will, for people who are thinking about a dental approach, especially women, for their sleep apnea?
So, there's a full spectrum of care, and, we start at very young ages where we can assess young children, and if they don't have a large airway, we can actually work with their growth and development and actually grow the airway. And you can make significant changes in that all the way up to almost the 20s. So it's not like it's optimal if we can catch them between the ages of, say, 4 and 8. That's like just a great time, because young children grow so rapidly, and you can make significant changes there. But we still can make changes. Nowadays, as orthodontists, we used to be able to do expansion only in growing patients, but now we have ways of doing expansion all the way, through adulthood. So we can always enlarge the oral cavity, which gives more room for the tongue. And the tongue is the biggest obstructor of the airway. So that's another way. So, we can do orthodontics, we can do dental facial orthopedics. And then ultimately, when we have pretty severe patients, I have patients that have surgery where we can actually enlarge the jaws so they can breathe better. So
are you talking about MMA, the break?
Yes, MMA. MMA. Mm-hmm.
Yes. Okay. So basically, that's breaking the jaw and kind of resetting the bottom jaw. So you're kind of making it
surgically repositioning the jaw.
You're surgically repositioning the jaw. It can be in a very effective surgery. You got to go to the right person with that kind of training. That's a very specific type of training.
I do a lot of surgical cases, and you want the right team. And everything, people are like, well, you're just making it bigger. It's all by the numbers. And people that need surgery are deficient. So we're not making anything bigger than it should be. And if it's done right and well, not only do you get an amazing airway, you'll get a very lovely, beautiful aesthetic result.
And now, a quick break. But don't go anywhere. We'll be right back.
Struggling with sleep? Dr. Cole is here to help. Whether you need a comprehensive sleeping coach program, suspect you have sleep apnea, or simply seek a second opinion, she's available for consultations in New Jersey, New York, California, and Georgia, with more states coming soon. Schedule your free 15-minute consultation today to find out which visit is right for you at asktosleepmd.com and start your journey to better sleep with a trusted physician.
If you are liking this podcast, if you're finding it educational, if you are feeling more empowered to go to your doctor with any sleep issues that you might be having to address them, please, please, please lend your support. Make sure that you are liking, following, subscribing. I am available on YouTube. I'm also on Apple, Spotify, or wherever you get your favorite podcasts. The website has launched. So we have asktosleepmd.com to be your free educational resource. We've added many new blog posts filled with juicy information. If you would like to support the podcast, we now have a way for you to donate. This is a labor of love. I truly enjoy what I am doing. It would be inspiring and truly helpful if you wouldn't mind even so much as donating $1 to keep this podcast going, particularly if you really find this free education a good platform for you and a good resource for you. I also have affiliate links for products that I'm a proponent of, such as Quiet Mind. So please check out the website, sign up, and you will get the latest news, the latest blogs, some sleep tips, and just have a great day and keep listening. Okay, guys, sleep well.
But I wanted to go back a little bit too to what you were saying. So it's interesting. I think this is a great conversation that you and I could have over dinner. But, we're always talking about sleep apnea, but, we have to talk about the different kinds of sleep disorders. And so, to me, yes, I want to know about apneic events. I want to know about a collapsed airway. But I think the key is we have to look at quality of sleep. And so if we start to look at quality of sleep instead of counting apneic events or RERAs, we're going to be able to figure out there's a lot more people that have airway problems than we think. And the interesting thing about when people have, a high RDI but a low obstructive apnea count, these people end up with something called excessive daytime sleepiness because they have poor sleep. So one of the ways that we open the airway is by clenching and grinding. It helps support the airway at night. Women do more clenching, men do more grinding. But what women do is instead of having the apneic events, they're waking up, plus they're also clenching. Now, what happens with excessive daytime sleepiness, when you have that, unfortunately, the body's constantly trying to put you back to sleep. So you're sleepy during the day. And Allison, guess what one of the ways we recover from excessive daytime sleepiness? What do you think the body does? We clench. Daytime clenching is about excessive daytime sleepiness. Nighttime clenching is about a collapsing airway.
Whoa.
So
I did not realize that. Okay.
Yes.
Okay.
Yes.
Okay.
They're different. They're the same reaction to different sources. So this is one of the first things I ask people. Do you clench during the day or at night or both? And if they say I'm clenching during the day, I know they're not sleeping well. I don't even have to do a sleep study. Now, maybe they just had a baby. Maybe something like that happened. Maybe they had a parent just die. That's different. But if that's chronic, then we're looking at sleep. And then guess what happens if that goes on too long? They break their teeth.
Oh, yes. I've had so many patients with that. I've not separated the clenching, though. That is something I'm going to start to incorporate in my practice. I find that very interesting.
Yes. Daytime clenching is linked to excessive daytime sleepiness.
Question for you. Do you see an uptick in clenching as women get older and as that risk increases for their airway to be more compromised? I don't know if there's any literature about that. I'm curious.
the highest levels of clench, I mean, you can see it any time, but I tend to see it more in like 20 to 40-year-olds. I think it's a combination of, lots of stuff is working, they have children. Not only are they not sleeping well because of their airway, but they're not sleeping well because of other things. So
Stress.
they're both added together, and then they're really not sleeping well. I mean, I've had women come in, because on the one questionnaire I have is, do you ever fall asleep, like at a stoplight? And I had one woman tell me that she had trained her children to wake her up when the light turned green.
Oh, man.
That's
It's pretty impressive sleepiness.
But she didn't show up on a sleep study.
Amazing.
She didn't have
amazing.
Event. So my key of talking to you today is, we need to start looking at sleep for women differently and being able to pick out who is at risk for this and how we can help them globally so that they can have an improved quality of life. Because yes, I'm very concerned about people that obstruct. And, I see that in my women postmenopausal, and of course men even earlier. But I'm so worried about these women walking around sleepy all the time because it's a problem. And we always say, oh, well, I'm busy, I have children. We have excuses for it, when in fact, it's really a sleep quality problem. And then we have all those problems that go with it. Autoimmune disorders, memory problems, lack of thriving, growth and development issues. So all those risk factors are associated with it.
So you're bringing up a couple of really key points. One just being that women tend to complain less about their symptomatology. So it tends to be worse when we present. We know that, especially for cardiac disease, they tend to have a worse outcome because they're not saying anything. They're always, just pushing it aside, making other things a priority.
We minimize it.
We do. And I don't know if it's, cultural or a combination of our genetics and cultural, but women do this. It's like women have the responsibilities of taking care of the household, etc., and they tend to make themselves second. The other issue that's really key, and I do counsel my patients about this, is even if something appears to be, quote, RERA related, your RDI is elevated, but your apnea-hypopnea index is normal, right? One would make an argument, well, it seems like things are pretty mild. So what's the big whoop, right? And the reality is that I really try to hone in on patients' understanding that, especially since a lot of the data we get is from home sleep apnea testing, that mild, moderate, severe, I'm rethinking how I approach this, and the accuracy for what constitutes mild, moderate, severe, we may need to really rethink this whole paradigm, even in sleep practice and dental sleep medicine. Because the bottom line is that it's about how you're feeling and how your symptoms are, right? So even if you have an elevated respiratory disturbance index, but it doesn't look like you're really stopping breathing, and so someone's telling me, oh, well, this seems like it's mild, or your desaturations are mild, you're probably fine. If you are falling asleep at a stoplight, if you're truly having poor sleep quality, enough to bother to get that test, to come talk to someone about your symptoms. The bottom line is that you are worth treating. And this is an argument that I make not only with my patients, but also, if I have to, with insurance plans, because a lot of times there's stipulations, it's mild disease, but I'll consider it if they have hypertension, if they have diabetes. The whole idea here is that, can we try to stave off chronic medical conditions by maximizing sleep quality and minimizing obstructive sleep apnea? Because that seems to be the better way to go, is get you before you got comorbidities. Yeah. Even folks insomnia, you could say, oh, this person has insomnia and has some mild sleep apnea. For me, it's been really hit or miss if I can get that approved for certain types of treatments. Whereas, the excessive daytime sleepiness is easier because that's kind of a key feature. But the problem is a lot of women, their complaints they may not really report that degree of sleepiness, again, because we tend to minimize our symptoms in part. And the second part may be that we're just, not manifesting as sleepy and more, just sort of used to that, if you will.
Well, that's the biggest problem. People learn to tolerate things. And so something, if you just had it start happening, they might say, "Oh, that's sudden. I'm not sleeping." But if they've just adapted to it over time, they will always minimize it. And so that's why I really like to take the sleep study and have a real face-to-face conversation with them and say, "I know you say you're minimizing this, but your tests are showing you're not really sleeping very well." And then usually sometimes they just need to hear somebody else say they believe there's a problem. You can't imagine how many women tell me, "I've been to a doctor and they told me it's all in my head." And I said, "You know what? They're right. Your airway is in your head and you're not sleeping, and it is in your head, but it's not psychological. It is actually a problem. It's a physical
Oh my
problem
God.
you have, and it is in your head. They
I
just are
just
missing it."
I love the way you phrase that because we really do need to shift the paradigm for women. This is, I mean, for the longest time, it's like, the female hysteria. And I'm like, stop, please. Like, we've been underrepresented in research in this space. I mean, years and years and years of neglect and
Yeah.
sort of poo-pooing like we don't really understand females, so we're just going to let them go into like the mass hysteria crazy pile. We're not even
Yeah.
going to entertain the fact that they're just not dudes. It's okay for us to be who we are
Well,
and
and the other thing is
recognize
this,
that
is that,
uniqueness.
as you were saying, you're trying to correlate other things to help a possible underreporting of obstructive events, but we can help support that because we know that one of the ways that a challenged airway gets supported is through parasomnia, such as bruxing. And so if we're seeing grinding or clenching at the level of dental anatomy being altered, then we have to believe there is an ongoing, long-standing airway challenge. And so we have to be able to take that leap and say, this is not something that just happened. People that are breaking all their back teeth or people who have worn them flat, there's something that's going on a regular basis that is causing these people to destroy the hardest substance in our body, which is enamel. And so if they do that, their airway is being challenged a lot.
Wow, this has been such a fun discussion, Mary. Do you have any final words for people? My final word is, dentists listening, there are plenty of sleep doctors who want to coordinate care with you. We want to have that dialogue with you. And if you're around people who don't, find people who are, because we exist. I mean, I love the fact that I can have this discussion. I love that there is a viable alternative, either be it surgical and expansion wise or oral appliance therapy, which is, non-surgical, but kind of moving the jaw forward. Or
We do all
CPAP
that.
or implantable device. Like we've got this whole arsenal of ways to manage sleep apnea now that we really didn't have before. And then
Yes.
also going to somebody who is an expert if you're really clenching and grinding, and don't be sold that I just need a mouth guard and that's fine. I
Yes.
get that question a lot. Oh, well, I just have a mouth guard. That's the same thing, right? And it's
No.
not. It's not. So
Yeah.
recognizing that you need to go a step further with your testing may actually end up costing you less out of pocket too when you think about it, just in terms of cost effectiveness, because if you have an airway problem, which is highly likely, we're going to manage it. And then
Yes.
you're going to get the right treatment for it. So you're not getting a mouth guard that's getting replaced with an oral appliance or sticking you on CPAP anyway, that kind of thing. So what we're saying here is so key. And, it just so happens that it's International Women's Day as we tape this.
I
So,
know. I heard
mean,
that.
what a perfect conversation to have that. I
Right.
didn't even know that. So one of
It
my
worked
male
out well.
colleagues actually texted me and I was like, oh, I didn't even know it was International Women's Day. Thank you for being so feminist for me. I appreciate that.
Well, my final words are we do need to pay attention to the differences in women and men. And we can have this in another conversation, children and adults, which is very different. But yes, I have a team put together. I'm so happy, Allison, you're going to be on my team now. And, we have a whole lot more to talk about. So when and if you want to talk, one of those are about pregnant women and lack of ability to conceive and all those relationships with women
yes.
and sleep. So there's a whole lot more to talk about, and this was fun. And my name is Dr. Mary Burns. I'm at New Hope. It's newhopeorthodontics.com if you want. That's my website. You can email me at drmary@newhopeorthodontics.com if you have any questions. And it was wonderful talking to you.
Yes, Mary, this is a legit person. She knows what she's doing. She's been hugely instrumental in my relative's life, and you really have an expert in her. So if you're in the Pennsylvania area and you need to check her out, do it. You're not wasting your time by going to her.
Disclaimer. The statements made on this podcast have not been evaluated by the U.S. Food or Drug Administration. They are not intended to diagnose, treat, cure, or prevent disease. The information provided by this podcast should not be used as individual medical advice. While I am a practicing sleep provider, I am not your sleep provider. You should always consult with your personal healthcare provider for individual recommendations and treatment.